should we go ahead for the last topic, which?
Yes, sir.
Okay. So this is the last topic which we are going to have. This is evidence-based medicine. Now this term actually we have seen many a times. If you remember all the guidelines, in that we have seen many aspects related to evidence-based medicine. Can anybody just tell what do you understand by evidence-based medicine?
So making clinical decisions based on the evidence which is available.
Very good. The clinical decisions which are made on the basis of the evidences available. Very good. Very good. Okay. Anyone would like to add anything or modify anything? Very good. So these are basically, yes, evidences. On the basis of the available evidences, the clinical decisions are to be taken, and this evidences also we have to make it in a hierarchy, that which evidences should be considered as the best, which evidences should be considered as a moderate, which should be considered as a low level evidences. Because if we make it just evidence based and somebody says that this is my evidence, but again that appropriateness of the evidence is also actually part of that evidence. Okay, so not only evidence but the appropriateness of the evidence is also important for the clinical decisions. Okay, and this is a dynamic condition, that is, it is not once or whiles. Today I have taken some decision, I have found on the basis of evidences, and then I'll stick it for year and years or generations and generations, then it is not useful. That means it should be dynamic, it should be reviewed, it should be verified, it should be confirmed. Okay, if today's context we see, if you remember, those who are reading or those who are following corona related treatment related things very carefully, then you will find that initially there were no evidences, so everybody was including all the doctors, experts, they were very confused. Okay, so then some evidences start pouring in, so many WhatsApp messages, Italian doctors has done biopsy, autopsy, something like that, post-mortem, and they found this has happened. But at the same time other clinicians, they were also working. These are, if you forget about WhatsApp messages, and then as an as and when the information that was improved, accordingly treatment plans improved. Initially mostly it was a very haphazard, which are totally unscientific, or we can say in contrast to evidence based medicine. It was there, there was a hydroxychloroquine boom, and it was told that hydroxychloroquine is essential. It was so big that even the President Donald Trump, that he said that no, India should supply us hydroxychloroquine, and that is only the remedy, and we know it. Later that evidences that show that it was not an remedy, or it is not causing any good benefit, rather it has caused many harm to many people. Then all of a sudden somebody found that ivermectin is very good, then all the thing that went to ivermectin, and same thing followed for remdesivir, for many other things. Then all of a sudden people found that there is a role that is called as a cytokine storm, and you need to have some role for immunosuppressant agents, and again in that also so many things happened. So later those who were good experts, they later came to conclusion that the timing of various medication is equally important than the as the selection of the medicines and the things. So this is how science evolves, that continuously observation, continuously making the records and studying it. So basically science is what, this is what it is, based on the intelligence hypothesis. So hypotheses are there, and these are not layman's hypothesis, something like that कि इससे ये अच्छा हो जाएगा. It is based on certain intelligence, based on certain scientific backgrounds, and this hypothesis is made, and the person who is making that hypothesis, that has, because the persons, they are not the butchers, or they are not merciless people who are just want to kill people like that. So they will be trying, they should be having some justification, they will accordingly apply, they will submit it. So hypothesis is that the hydroxychloroquine, or maybe ivermectin, or maybe any other drug that should cause benefit, or that should reduce the corona infections. That was the hypothesis. Then we have got series of experiments and analysis of various results, and we still see that the hypothesis is correct. So if this hypothesis is correct, on the basis of that, the evidences are there, and accordingly we can prove. But again, these evidences should come from a very good and very clear good studies. Again, if you will find that initially those who want, they can just go for that. The Lancet is one of the very reputed journal relating medical field, and Lancet was so much pressurized to publish an article that hydroxychloroquine is not at all good without any data, and that was very what we can say, angrily reacted, or people reacted very strongly against it, that this is not the way Lancet should do. Okay, and actually maybe now it was proven that Lancet was correct, but then the method was not correct. Those who want, they can search it, Lancet hydroxychloroquine, an article, and that article, the journal has to withdraw the article. If any article is withdrawn, that means that is not good thing for that particular journal and that particular researcher. That means that they have not followed the proper guidelines, proper care, it was not there. So that means it can happen that the Lancet who have published it, which was not having a strong or supporting data, people called for data was not available, they could not give the data, but they just told that no, hydroxychloroquine will not work. The scientists who were firm believers of hydroxychloroquine, they said that no, it should work, and when they asked data, they could not provide. So that means that if we consider about it, the Lancet was an evidence that hydroxychloroquine is not effective. Okay, and there are many other journals also, they say that, or many articles, they said that hydroxychloroquine is effective. Now that is a dilemma, that is the problem. So on that basis, again, when the good researcher or the good clinician has to follow, he will follow the reputation. Then what is the reputation wise? Lancet has got a good reputation comparatively, because there are many factors. One of factor is impact factor, etc., old traditional reputation, etc. Now if these things like happen, then the reputation of Lancet will go down, and the other journal which has submitted the data which is more scientific will come up. So these are various factors we contribute, or these are contributing for the level of evidences, that is what kind of, or what is the quality of evidences. So this is another important thing, that various experiments and the analysis of results that will be prove that the hypothesis is correct or not correct, and lastly, whether this hypothesis whatsoever is there, whether it is replicable universally or not. Example, again in Britain, people are saying it is effective. In US, they will say it is not effective. In India, they will say effective. In China, they will say not effective. Some other countries say that one group says effective, other is not effective. Again, this is confusing. So that means you should have a data which should be somewhere coherent, which should be somewhere matching, or which can be given for a clear-cut judgment. Then if it is not, then again it may make a problem in that considering that evidence as a proper evidences. So this is how we are going for that. What do you think that what are the benefits of evidence based medicine? Or what should be the
Medicinal adherence will be improved.
medicinal adherence will be improved? Okay. Any other thing? Any other thing?
Control ADRs.
Control areas. Okay. Okay. Any other thing? Basically, you understood what is evidence based medicine. What is evidence based medicine? Let us revise it. What was it? Yes, we started with evidence based medicine. What it is?
Making clinical decisions on the basis of quality evidence which is available.
Making clinical decisions on the basis of quality evidences. Okay. So, when you are using the best evidences, or you call it as a quality evidences, and then when you are taking decisions, so what do you think, what will be the outcome of these decisions? Where these decisions will lead you, where they will carry you, where they will take you? Okay, whether the medicine is beneficial or not. Any other thing? Good clinical practice, very good. Okay. When you are following evidence based medicine practice, what you are ensuring? What you are ensuring?
That we provide a proper treatment and not unnecessary drugs are administered to the patient.
Very good. You are providing proper treatment and no other unnecessary drugs are administered. Very good. So, what do you think? What can be the outcome of this?
We can ensure minimal risks of ADRs and maximum benefit to the
Very
patient.
good, very good. Maximum benefits to the patient and minimal ADR. Very good. What are the further outcomes of because of this? So this is the first immediate step you got, that the best possible treatment was provided, which is having highest efficacy chances and lowest adverse reaction chances. Very good. Okay. So what can be the outcome of this? Again, next is, as next year you will be studying, we call it as a pharmacoeconomics. So economics wise, there is economical benefits the patient will be giving, then health related benefits patient will be getting. Okay. And the best possible treatment is there, good prognosis, as we have discussed. So good prognosis it will be giving, and with minimal adverse reactions. So because of all this, it will impact on cost, it will impact on the health, that is benefit health, minimum cost, maximum benefits in the health, and overall, if society wise or the country wise or the world wise, that will give the benefits that the best possible treatment is being followed, and accordingly the maximum benefits one can get. So this is what the benefit of that. Okay. So it is what the integration of the individual clinical expertise and the best external evidences, they are integrated. That means, suppose I am a very good clinician and I feel that hydroxychloroquine is very good one, I will propose it and I will check it. But since I am doing it, I may be biased because I want to prove myself, I am the expert, I am the best. But what others are telling, okay? And clinical research, if you are studying, there are various clinical trials, I think it is in 5th year. So there are various ways by which you are performing clinical trials, and on that base of clinical trials, okay, so that gives the idea, that gives the information, and accordingly the other people, when they go for that, what are their results, because they may not be biased, okay. There may be some people who want to prove me wrong, they will be working against me. There are many, rather they will be neutral one, ठीक है, he is telling let us check, they may be at least having idea, yes, the person is expert, so if he is saying something, it should be examined. And there are other who is also equally expert and he said that it won't work. So both are experts, both have their own good knowledge which has been proven. So let us verify neutrally. So there may be many people who are doing it neutrally, and on that basis my experiences and so many people's experiences, they will be integrated together, and on that basis, okay, that will come on that basis various qualities of RCTs. If you remember again, earlier slides we have seen, that is level of recommendation and the what kind of the quality of this was there. So level of recommendation was 1, 2, 3, 4 it was made, that means it is the best, okay, or to what we call it as a first line treatment, and what kind of the quality of evidences are there. On these two bases our guidelines are made. So evidence based medicine are actually the framework, or it is the basis which is making your guidelines, okay. So once these evidence based medicines are there, on that basis people will use it. This all will be discussed on various forums, and finally it will come as a guideline. So if it is proven successful, it will come as a guideline. If it is failed, then it will be removed, or it will be considered in the second line, third line treatment, or not recommended classifications. So if you remember earlier, we have seen various drugs and their situations. So how the drugs are there, and whether it is what we can say level 1, level 2, level 3, okay, what are the type of recommendation, what is the class of recommendation, and what is the evidences or quality of evidences. So these are two things, when we combine accordingly, they are leading to guidelines, and these guidelines are the guiding forces, they are the important documents for the clinical practice. So this was the editorial which has given the introduction long back in around 2006. So what is, again, as we have seen, we should have the best evidences. As I told you, on what basis we call them as the best evidences, because not only evidences will be important, their quality of evidences will be equally important. मैंने 15 लोगों पे टेस्ट करके बोला कि yes, I have got evidence, it is very good. Somebody said that I have done it 500 people, somebody said I have done it 5,000 people, and every study was, when we go for that various clinical trial designs are there. So well designed, the best designed study with all factors they are put into, then that will be called as the best evidence, okay. And these best evidences should be given, or they will be prioritized, they will be given higher weightage than the low one, okay. And then that will help us to make the clear decision making. So these are the best evidences. These evidences are most widely read, referred, and why they are very widely read and referred, because they have done it in very, very scientific manner. They have put in very good number of observations, that is number of patients, whatsoever it may be. They have put in very good number of patients into it, and they have made all the things very clearly, therefore the decision making will become easily. So what are the various types of studies? I think you should just have an idea about it. Even when you will go for clinical studies, at that time you will have this. But first one is observational study. Observational is, we are evaluating the results of condition of the treatment in a defined population. In that we have two type of observational studies. Here we do not recommend any change into that. Whatsoever is going on into that, suppose this is a treatment which is going on, which is old and recommended one, we are just observing it. Okay, so we can do it in two ways. We can do this observational in a retrospective way, that is last 5 years records, पेशेंट कितने आए थे हॉस्पिटल में, उनको क्या ट्रीटमेंट दी, उसका आउटकम क्या हुआ. दिस इज व्हाट वी कॉल एज ए रिट्रोस्पेक्टिव. प्रोस्पेक्टिव मीन्स अभी पेशेंट एडमिट है हॉस्पिटल में, आई एम गिविंग द ट्रीटमेंट एंड व्हाट इज हैपनिंग टू द पेशेंट्स, उसको साइमल्टेनियस जैसे जैसे ट्रीटमेंट शुरू है, व्हाट इज द आउटकम विच इज देयर. ओके, दिस इज कॉल्ड एज ए प्रोस्पेक्टिव. सो बेसिकली observational, retrospective observational, it can be prospective observational. Observational means you are not doing anything, means whatsoever being there, you are just observing it. It doesn't mean that you are not giving any treatment, but you are giving the treatment which is the routine one, which is the as per the guideline one, which is the normal practice of that particular hospital for that particular disease. So this is what observational. Then next type is known as a case control studies. Case control means series of patients are there with particular disease or conditions, and they are contrasted with the match control patient. Okay, that means hypertension patients are there, another are hypertension patients. Okay, and in one patient's treatment is going on, in other patient treatment is not going on, in patient routine treatment is going on, in other patient maybe some a diet or something is going on. We call it as a case control section. That is, case wise we have separated and we are comparing it with the control patients. Okay, matched similar patients, same usually similar population. Suppose अगर ट्रीटमेंट में भी 20 से 60 की एज ग्रुप है, सो अनट्रीटेड विल आल्सो 20 to 60. ओके, सो दिस इज व्हाट केस कंट्रोल स्टडी. क्रॉस सेक्शनल स्टडीज, these are the measurements made on a single occasion, and they are not looking at a whole population but selecting small similar group and expanding results. So on single occasion, 2 days में क्या हुआ, या थोड़ा सा पोर्शन ले लिया एक कोई भी टाइप का, कि दैट इज कॉल्ड एज ए क्रॉस सेक्शनल एरिया. ओनली सिलेक्टिंग अ स्मॉलर सिमिलर ग्रुप एंड विल सी दैट इज क्रॉस सेक्शनल. मतलब कोई भी डिसीज़ है उसमें से बच्चे अपने सेपरेट कर लिए, सो दिस इज अ क्रॉस सेक्शनल. ओके, सो एंड एक्सपांडिंग रिजल्ट्स फॉर दैट, इसमें से जितने बच्चे थे उनका रिजल्ट अपन ने एक किया. Longitudinal measurements are taken over a period of time, not looking of the whole population but selecting small similar groups and expanding results. तो एक स्टडी था, उसको कंटिन्यू कर दिया हमने. ओके, और छोटा ग्रुप लिया, उसको पहले एक ट्रीटमेंट जो देते थे उसी को कंटिन्यू करने के बाद व्हाट आर द इफेक्ट्स वी आर सीइंग, these are called as a longitudinal studies. That is, for a long period of time we are taking these results. Then next is the basic criteria was observational, second is experimental criteria. Okay, experimental is what 2 or more treatments are compared. Example, hydroxychloroquine, remdesivir, there are 2 treatments. Allocation of the treatment is under the control of researchers. तो किसको हाइड्रोक्सीक्लोरोक्विन देना है, किसी को रेमडेसिविर देना है, ये रिसर्चर करता है, ये रिसर्चर के हाथ में रहता है. इन दैट वी हैव गॉट, वी कॉल देम एज ए क्लिनिकल ट्रायल्स. जो भी ये एक्सपेरिमेंटल एक्टिविटी है, वी कॉल देम एज ए एक्सपेरिमेंटल कंडीशंस. Okay, and we also call them as interventional studies because these are new interventions are there, we are modifying it. So in that, first one is known as a randomized one, that is two randomized allocated treatments are there. तो दो ग्रुप लिए, उसको रैंडमली ग्रुप ए को हाइड्रोक्सीक्लोरोक्विन दे दिया, ग्रुप बी को रेमडेसिविर दे दिया. दिस इज व्हाट रैंडमाइज treatments. Okay, next is randomized controlled, where you are having one more group that is called as a control group which is having no treatment. तो कंट्रोल ग्रुप को अगर ट्रीटमेंट से बेनिफिट नहीं होता है और उसमें सिमिलर कंडीशंस हैं, सभी के सिमिलर मान लो वैल्यूज़ हैं. ओके, अगर कोरोना की केस लेते हैं हम लोग तो मे बी सिमिलर सिटी वैल्यूज़ और सिमिलर रेंज ऑफ सिटी वैल्यूज़. कोरोना के टेस्ट के बाद सिटी वैल्यूज़ आती थी, अगर इफ़ एनीबडी नोज, है ना. सो इफ दैट सिटी वैल्यूज़ आर देयर और सिमिलर ऑक्सीजन कंट्रोल कंडीशंस सिमिलर और एवरेज, तो सबका सेम होगा. अगर ये ठीक से नहीं होगा तो क्या होगा, देन योर रिजल्ट्स विल बी बायस्ड. मान लो मैं ट्रेस कर रहा हूँ और मैंने जिन लोगों को सीवियरिटी कम है, कॉम्प्लिकेशंस कम है, उनको मैंने कहा कि नहीं नहीं इसको हाइड्रोक्सीक्लोरोक्विन देते हैं, और जिसको सीवियरिटी ज़्यादा है उसको रेमडेसिविर देते हैं. देन व्हाट विल हैपन, you will say that you will able to prove that hydroxychloroquine is superior to remdesivir. वो भी एविडेंस बन गया, बट देन द क्वालिटी ऑफ योर एविडेंस इज नॉट गुड. ठीक है, बट इफ आई एम गोइंग फॉर दैट, देन आई विल सी दैट द केसेस, द एवरेज एज ऑफ द पेशेंट्स वॉज मे बी सपोज 50 years. Okay, then average is 50 years with almost similar standard deviations. मतलब इसका मतलब है कि स्टैटिस्टिक्स में पिछले इसी साल आई थिंक ना 4th ईयर में आप लोगों ने सीखा होगा, स्टैंडर्ड डेविएशन विल गिव दैट इसमें वेरिएशन कितना है, अगर 50 के प्लस वाले कितने हैं, माइनस वाले कितने हैं, इससे आपको स्टैंडर्ड डेविएशन मिलेगा. तो स्टैंडर्ड डेविएशन शुड बी ऑलमोस्ट सेम. ठीक है, क्लिनिकल कंडीशंस का भी एवरेजेस निकालेंगे, मे बी सिटी वैल्यू का निकालो आप या ऑक्सीजन लेवल्स का निकालो, again they should be matching. Then if you are going, then they are going, that means a good design you are having. So it can be randomized, it can be randomized controlled trial. Okay, so these are the observational studies. We are evaluating only the results of the conditions and the treatment in the defined population. पहले देखा हमने. रिट्रोस्पेक्टिव आई टोल्ड यू, एनालाइजिंग पास्ट इफेक्ट की 2000 अगर कोरोना लेते हैं तो मान लो जनवरी 2020 से लेके तो सितंबर 2020 तक के केसेस का क्या हुआ, तो कौन सा पेशेंट, क्या एज, कितना, उसका डिटेल जो तुम्हारे मेडिकल रिकॉर्ड में अवेलेबल है. यू आर जस्ट गोइंग, ओपनिंग द मेडिकल रिकॉर्ड, checking that, checking the treatment and checking the outcome. So this is what we call as a retrospective. Prospective मतलब अभी जितने लोग एडमिट हैं उनको क्या कंडीशन है, उसमें क्या ट्रीटमेंट दी जा रही है और उसका क्या आउटकम है. So this is simultaneously, this is what we call as a contemporarily, okay, or continuously. Already we discussed all this. Case control is what, cross-sectional is what, longitudinal is what, experimental is what, randomized is what. So the best treatment, best combination of all is a prospective randomized control, and that is called as a gold standard, gold means, and in most of the research you will find that word as a gold standard. Okay, so randomized, controlled and prospective. Prospective means ongoing. Okay, it is not previous data, it is current one, simultaneously whatsoever going on, and this is randomized and controlled. Randomized why we call, because patients were not selected by choice of the researcher. Patient were selected, group of patients were made. Suppose in Aurangabad hospital there are 300 patients of COVID, then all these 300 patients will be there. They will be divided in a such a way that their averages will be almost similar with standard deviation, so that any group can be randomly selected and any person, these two groups are randomly selected, and this random selection will be go for A group, any will go for B group. मैं ये ग्रुप लूँगा, मैं बी ग्रुप लूँगा, ऐसा नहीं होगा. और हियर इट विल बी थर्ड मोर ग्रुप इज अ सी ग्रुप सपोज. So it will be without treatment, what will be happen? This is called as a, and very popularly word you will find that this is called as a RCTs, that is randomized controlled clinical trials, okay, or randomized clinical trial. So these are known as a RCTs. अगर तुमने पहले अगर देखा है wherever you will find that what kind of RCT and design of RCT, जो level of evidences में word आया है. इसके पहले जहाँ भी हमने गाइडलाइंस देखी थी वहाँ पे ऑन द बेसिस ऑफ टाइप, दैट इज क्लास 1 रिकमेंडेशन और व्हाट इज द लेवल ऑफ एविडेंसेस. सो लेवल ऑफ एविडेंसेस में जहाँ RCTs आर देयर एंड हैविंग गुड अमाउंट ऑफ ऑब्जर्वेशंस, दे आर कंसिडर्ड एज अ बेस्ट वन, और जो बेस्ट का एविडेंसेस है दैट वाज टेकन एज ए प्रायोरिटी एविडेंसेस. Now this is again statistics which I will ask you in our next class, that is what do you mean by confidence interval and what is its significance, then what is relative risk and what is its significance, what is hazard ratio and what is odds ratio and what is its significance, because this year you have studied all this in this one. So I want that you submit the details for this, what do you mean by these three terms, and we shall see how they are used in that. What is confidence interval? Okay, and that is denoted by p values, which is different than probabilities. Then what is relative risk? And if you remember earlier, we have seen a graph like there is a one vertical line, and the graphs are spread across this vertical line, and accordingly we can judge from that. This type of graphs we have seen earlier. Odds ratio we have seen, odds ratio also we have seen that way. So these are various graphs we have seen earlier, but I like that you go through this and you will give information about it. Now second thing is how we are utilizing the resources, that is literature. So literature should be reliable. Just now I told example of what Lancet. Lancet was is one of the most reliable one. But as soon as it was found that the article which was not having a good basis and which was published by Lancet with recommendation that hydroxychloroquine is not a good drug, then the people will fire it. People will actually get angry and they will respond it very strongly. So whatsoever reviews are there, whatsoever studies should be there, they should be reliable, they should be systematic, and very good methodologies which have followed, very good designs they have followed, and these are predefined designs are there. In clinical trials, designs are very, very important. You have to plan everything, and if the plan is good one, plan is the design is proper one, then only your results are more acceptable. So go for that. Minimize bias. So for minimizing bias, randomization is one of the technique. Blinding is one of the technique. We call it as a double blind techniques, where nobody knows that what kind of treatment is going to given to what kind of group. So this is another techniques are there. You learn all these things into when you go for clinical research. So this is what minimization of bias is very important, because there are many important aspects of there. And then you read all these systematic reviews are there which are appeared, all the articles, you go that and you apply statistics over there, and that is called as a meta-analysis. Those who are interested can just check what do you mean by meta-analysis. Meta-analysis is a term which is used that suppose I have got 100 articles on corona, particularly corona treatment. Then I will find that there are 5 articles that are telling that hydroxychloroquine is very effective. There are 5 articles they will say that it is not that effective. 5 articles say that it is no effective and there are no much adverse effect. There may be some articles I'll find that it shows more adverse effects. So like that I have got variety of articles. Okay. Now in that simultaneously I'll apply that in which how many cases were there, how many observations were there, and what is the reputation of that particular journal. So on that basis I'll put this, and then accordingly I will go for that. This is called as a meta-analysis. So similarly for remdesivir, for comparison between 2 drugs, 4 drugs. So from that all this information will be collected, and all these journals will be referred, their methodology will be checked, their statistical activity will be checked, and then I'll reach to a conclusion to what I'll call as a meta-analysis. So this meta-analysis is one of the very, very important backbone of the evidence-based medicine. Okay. So this is how systemic reviews are prepared. So there are background information people are having, expert opinion. Example, I said that, I told you, I'm repeating this example again and again. I am a known person in the field. I said that hydroxychloroquine is a very good drug. Okay. So this is my expert opinion. To confirm that opinion, I am going for the next stage, that is called as a case control studies. So I'll go for that, or I'll case series. Case series means these are not very controlled studies, but I have given to 2 patients and I'll publish it that I have given it to 2 persons and they were benefited, and I'll continue it that again I'll say that I have given it to 5 people, but these are not controlled studies. There is every chance that the person who were not treated, they also got cured with that, but I have not noticed because my attention only is on hydroxychloroquine. So case control studies are there, case studies are there. Then we'll go for the cohort studies. So that is having, one plus other plus third, like that. At various places we'll do it, because people, those who believe me is a good person, they will participate into it, and that will lead to a cohort studies. But then when so many reports are appearing, there is a, interest in people will come up. They will also try to do it, and then it will go for the randomized control trials, as I told you, that is called as RCTs. And these RCTs may be done at multiple places. Okay. And at multiple places, when they are done, on that basis of their design and quality, this information will be coming up. So for case studies, it can be biased, cohort can be biased, even RCT, if I have done, it can be biased. But when all these 3 is coming together, and when this coming as an article, that becomes a filtered information, because when everything is appropriate, then it will appear as an article. And when these articles are coming, so many articles are coming, these articles will be taken up as a evidence synthesis, that is as a part of evidence accumulation or part of guidelines, and on that basis this systemic reviews will be made, and these systematic reviews will be the ultimate choice that will be given, that yes, that means that everything has done properly. These terms we have seen many a times, level of evidences and the class of recommendation. If you remember earlier guidelines, then these are same, many times we have discussed this. I'll suggest that you go through that. I'll also discuss with this next class. So before next class, I am expecting these 2 things you are doing, all these statistical terms just now I told, and go for this particular thing, that is these terms we have seen, that is what is the level of evidences and what we call it as a class of recommendation. These 2 things are very, very important. So go through this, and accordingly we will go ahead. Okay. So take care and be safe. What about questions? Those who have not given, please add the questions and send these questions. Okay.
Yes, sir.